Great. So I think we can start it. So hopefully there are no other technical issues. So what's myelography? Myelography is intrathecal application of non-ionic contrast medium via atlanto-occipital or lumbar intervertebral space. So during the lecture, we will show the correct ways, or there are two possibilities. There's a cranial punction, it's atlanto-occipital, and lumbar puncture, it's L6, L7 application. So all the cases or all the patients during we are performing myelography, they always have to be under general anesthesia. There is no possibility to sedate them just for any application, but it's necessary they have to be under general anesthesia. They have to be well monitored. So on the screen on the left side, you can see our anesthetic machine with all stuff which we are monitoring. And for good kind of visualization and minimalizing some movement artifacts, it's necessary, or in my field of view, it's necessary they have to be ventilated. Why is it better? Because you are able to do what you want. There are no breathing artifacts because you are possible to manage some apnea during some kinds of scans. But usually for CT myelography, it's not necessary. So they just could be ventilated, and we are trying to afford some moving during applications, and we could afford some moving artifacts. Usually we are performing scans in dorsal recumbency, and we will see it in the future. So myelography, we can apply it via two spots, and the first one is cranial puncture, which I told, and it's atlanto-occipital region. And the second spot is caudal puncture, usually L6, L7. There are some other possibilities, L5, L6, sometimes L7, S1. The best for me is L6, L7. On those pictures, you can see the anatomical regions with the needle for the puncture. So this is protuberances occipitalis externa. This is C1, and there is a cisterna magna here, and you can see on the top there is a needle. We have to be careful with going through the channel, because we don't want to go through the spine with the needle. On the second picture on the right, there is caudal puncture. For me, it's much easier and much safer, but you are not always allowed to do just caudal puncture. Sometimes it's necessary to combine a cranial and caudal puncture. And so for the caudal, it's much easier and safer, because in this region, there is not normal spine. There are some spinal big roots, or some, there is a region of caudal equina. So there is not big issue to damage spine, you should be careful, but there is no big possibility to damage something. And how we can perform it, we can go through the presentation. So for the myelography, I'm using yopamerol, 300 milligrams per mil. It's standard concentration, and my dosage is 0.3 to 0.5 mils per kilo. And sometimes I need to increase the volume of the liquid which I'm applying into the spine channel. So sometimes I use a dilution. So I dilute it. It's not 300 milligrams per mil, but usually it could be 200 micrograms per mil. And the rest of that volume is saline. And it's better to increase the volume for better visualization. So I use it quite a lot, and in my hands it makes big differences and nicer quality of images. On the right picture, there is a spine needle. There are a lot of types of spinal needle, and usually I use this one for all types of animals. For bigger one, I use black one, but 80% of animals I can perform with this one. So now I will describe the caudal puncture, then I will describe some advantages and disadvantages of cranial puncture, and then we will go through some cases. So for caudal puncture, we perform triangle with a finger. We will put 2 fingers on iliac wings and 1 finger on spinal process L6. And what is necessary, that needle should be perpendicular to the spine. And usually that's trick that you have to go very, very perpendicular. And if the needle is not perfectly perpendicular, you could miss the right spot when you are going through the channel. So there is some video on the model and on the real case. So the model on the left side, I'm trying to show you how I'm preparing my fingers. So on the model, there is no L6 spinal process. This is L7, but it's just for the demonstration. So I will try to show it once more. You could press the iliac wings with the 2 fingers and 1 finger on the spinal process, and what you can see, the needle is going quite perpendicular to the channel. So that's the right spot with the application. Here it's on the live animal. It's quite a huge dog, so I use 2 fingers for spinal process, and there is a just application of the needle. So this is how I perform the caudal myelography or caudal puncture. This is parallel video of the puncture and fluoro. So you can see once more the application between L6 and L7, and when I am in, that's done. So on the fluoro, you can see intervertebral space, and just going through the intervertebral space into the spinal channel. On the bottom, usually you can go on the bottom and then move 1 millimeter back, and you are on the right spot. You should be subarachnoid space. The next video is the same, and then there is an application of contrast medium. So on the left picture or left video, you can see a real application from the syringe through the spinal needle into the channel. And on the right side, there is a synchronic video of the application. So there is a needle on the bottom of the channel, and I'm applying the contrast medium, and you can see how the contrast is going through the channel. So this is one part of application. On the next slide, there is the same part, but I change the colors of the fluoro. So I think it's a nice demonstration of that area which we are filling. So you can see the syringe with the contrast medium, and there is a needle, and here's the contrast medium in the spine channel. This is the same for whole lumbar part of the spine. So the same point, the same of application, and there is a contrast medium around the spine. Cranial puncture. There's also triangular spot. We put our fingers on the ala atlantis from the both sides, and protuberantia occipitalis externa. I will show you on the next slide. And for small dogs, I use normal black hypodermic needle. For larger dogs, I use the spine needle, as I showed you on the slides before. And how we are performing the cranial puncture. The dog is on the lateral recumbency. We just palpate 2 spots. So this is the protuberantia occipitalis externa. Here are alar wings, and our needle is going perpendicular to this space. So here is a protuberantia occipitalis externa, and just behind that protuberantia, there's the right spot for application. What's necessary before application? You have to turn the head to the chest. There's, I don't know, 90 degrees flexion of the head. It won't be as much as it possible because it's closing, but in the right angle, for example, 90 degrees, it's opening intervertebral space. So my assistant took the animal head to the 90 degrees of the position for the neck and head, and then there is application. I'm a left-hander, so I'm sorry for the video that you couldn't see perfectly the needle at the beginning, but now you can see the liquor is coming out, and I'm in the right spot. So this is CSF collection. CSF collection is the first step before contrast medium application. So usually it's a good way to move the same amount of the liquid out as you would like to apply the contrast medium in. Usually it's not possible of equal volumes, so usually we take from 1 to 5 cc's. It depends on the animal's weight or how the animal is big. And after that, we are applying the contrast medium inside. The biggest trick for application for the contrast from the cranial puncture is the animal should be elevated in this part. So head and neck are higher than the rest of body, and we are using the gravity for contrast, which is going lower. But for this kind of application, usually the contrast medium is also inside the ventricles, and that's what's causing some problems, not just from the cranial puncture. It could be also from the caudal puncture, and that's what the most of people are afraid to do the myelography. That's some kind of seizures after myelography. It could happen. It's not something what's strange. It's some kind of adverse reaction after contrast medium, and you should be prepared to solve this problem. So if there are some seizures after that, you should calm the animal with some benzodiazepines usually, and it takes some time, usually 1, 2, 3 hours, and then it's done. So it's necessary to leave those animals after myelography for I don't know, 3 to 4 hours after that procedure at the hospitalization, and take care for them. And if everything is okay and they are awake and there are no seizures, they could go home. So I don't know what's the biggest scare to don't do myelographies. What I heard from my colleagues usually is something scared for them are seizures or non-proper application or some kind of damage of the spine. Yeah, it could happen, and the contrast medium shouldn't be applied into the spine. So that's something what should be take care. So myelogram's interpretation, there are 3 major lesions which we are looking for. So it's extradural lesion. So the most of disc diseases are extradural. The second kind of myelogram interpretation is intradural extramedullary lesion. So this is spine, and this is extramedullary lesion, and the third one is intramedullary. So the lesion is in the spine. For some interpretation of CT, we have to know some axis for good interpretation of the CT. So this is a transversal view, this is sagittal view, this is frontal view, and we use all three views for examining and reading CT myelographies. So that was some theoretical beginning, and I've got two cases for spine. All of them we perform surgically. So this is the first one. It is Daisy. Daisy came with acute onset of tetraparetic. You can see there is very low, deep sensation on all four limbs, but she's not possible to walk anymore, so that she is tetraparetic. And what was working well was just her head. So there are some parts of neuro exam. You can see no possibility to stand on the leg, and deep sensation and pain sensation wasn't good on the forelegs. So we perform the first native scan, and what you can see here is that you can see nothing, and that's very, very important part of this lecture, that there are a lot of calcified discs which can go through the vertebral channel and do some protrusion or extrusion. But if the material is not calcified, you are not able to see it perfectly with a native CT. So that's a reason for myelography. There are some rules how to judge intervertebral spaces. Usually you are counting 3 vertebrae, and you are trying to judge each vertebral space to other, and you are looking for the if there are some narrowing spaces which are suspected for some lesions. And on this scan, I'm not really sure that there is something which is showing something wrong. But from the clinical examination and neuro examination, we know that there was high possibility of neck disease, which was causing by mechanical problems. So we were looking for some disc material in the spine. So after native CT, we perform myelo, and what changes we can see here. So this is first view on the bottom of the channel, and you can see the big hole in the myelo. So what we are looking for on the myography is usually the line which is surrounding the spine, and the line should be very clear and straight, or not straight, but it should following the spine. And in this place, there's nothing, there's no contrast medium, there's a hole, and the contrast line is then continuing on the, on this side more caudally. So this is right side, this is left side. It is more on the left side, but the biggest information from this scan is that there is some ventral compression. We can saw it on the other axis. I will show it here. So this is more focused on that intervertebral space. We will go back to the overview here. So this is a second, third, fourth, fifth. So it between the fifth and the sixth intervertebral space. There is a ventral compression on this transverse scan. So now we can see it in more detail. So you can see there is not big, but very gentle narrowing of the intervertebral space, but you can see how big narrowing on the spine is here. So in my eyes, there is more than 50% of the channel compressed by disc extrusion. So this is C5, this is C6, and that was the diagnosis. So here it's different view. It's transverse view, and you can see how big compression on the ventral part it is here, and there are some other toys which we can perform on the CTs. So this is 3D reconstruction of the myelography, and you can see 3, 4, 5, 6. There is disc material in the spine channel. So what we perform, it was ventral slot. So we removed this part of bone in the middle, took the disc material out, and this was that same dog, I think 3 or 4 days after surgery. Not perfect, still limping, but able to move. A second case, I don't know the name of that dog. For example, Dusty. Dusty was operated on our clinic, I don't know, 2 or 3 years before for the neck spine disc problem. And nowadays he came with paraparesis with acute onset. The owner was very smart and clever, and he was asking for CT examination, and then he was prepared for the surgery. So we perform CT. So the first step is always native scan. After that, myelo, and you can see the ventral compression on the right side. It was, I think, TH13L1. I will count it later on the other view. So you can see the myelo, how can improve the quality of the image or knowledge about the spine problem, because without myelo, it's very hard to get this part to be seen. So in those cases, without myelo, you couldn't perform surgery well, because you are not able to know exactly where to do it. So on the transverse view, it was very clear, and we have some more details here. So this is sagittal view. There's also some spondylosis, but spondylosis doesn't mean any cause of those problems. And there was quite a huge ventral compression, and we know that the right side was worse. So we perform right-sided hemilaminectomy and take out this extruded disc material, and that was done. So also the hole on the bottom of the spine. So we perform, or we just see on the computer 3 axes, and we know what we are looking for. So in this case, was also very interested that if you look on the other intervertebral spaces, so here and here, there are no huge differences between those 3 spaces. And on the myelo, there is a huge compression, and the dog was paretic. So this was causing that problem. And I will recount it once more, and I think I should move my face from that part. 7, 6, 5, 4, 3, 2, 1. Yeah. TH13 L1, there was ventral and right-sided disc extrusion, and it was done by surgical way. So we perform hemilaminectomy and remove the disc material from the channel. Once more, the detail. There is other view. You can see the ventral aspect of the spine. So once more, the line of the myelo. This is cranial, this is caudal, and it is going from the cranial part, and in this vertebral space, there's missing the line here. There's everything missing because it's covered by this material here. And then the line of the myelo is continuing on the right side here. On the left side, you can see it's quite clear, and there is a bump here. So it was pushing, the disc material was pushing to the left side, and there was some deviation of the spine by the disc material. And what's good to see on the sagittal views are both lines, so dorsal and ventral line, and usually on the spot where some problem is, the both lines are not clear. There are some changes of the intensity of the myelo. So you can see that there's a small artifact here, but the dorsal line is not so clear as it should be, and the ventral part, that there is quite a huge compression here. So this was 3D reconstructed, and what's interesting, this is just a toy. It's not diagnostic tool, but sometimes it's manageable. But on this picture, it looks more severe TH12, TH13 intervertebral space here, but the disc material was here. So it is good to show those pictures for the owner, but usually 3D reconstructed pictures are not perfectly diagnostic. From my side, that's all. So if you have any questions, I'm ready to answer it. Here's the QR code with my contact. So if you want to scan it and send me some email with some questions, you are able to scan it. So thank you for listening to me, and I'm ready to answer your questions.
Thank you, Jan, for your time and for your skills, because your presentation is very clear, and I hope it could be useful for our colleagues to start doing myelography without fear. So if we don't have any question, I write in the chat also my email if someone have questions or something to ask to us. And also you have in the QR code the contact of Dr. Kuka. So thank you for everybody, and see you at the next webinar, and have a nice evening to everybody.
See you, bye.
Bye, bye-bye, thank you.